All right, guys, we're back with this week's lecture. We're going to start with obstetrics and neonatal care. We're going to start with obstetrical care first, which basically means we're going to be dealing with a pregnant mother up into delivery. All right, so this falls under the special patient population. I know that there's several portions of this the special patient population. We got pediatrics as well, geriatrics. We've got the bariatrics. We've also got like special needs children and patients and things of that nature. So that's what we're going to be dealing with in this section. Obstetrics. Let me just first by saying that a disclaimer. Like I said last week, I am not a woman. So with that being said, I don't know any of this stuff firsthand, but I will tell you that dealing with obstetrics, the majority of the time, delivery is normal. It's a normal thing. It's going to happen regardless of whether you're helping the pregnant mother or not. So with that being said, delivery, when it's time, it's time. I'll probably reiterate that several times, but when it's time to deliver baby, you're going to shut down camp, wherever you're at. If you're in the home, in the ambulance, pull over, whatever, and get as many hands on board as you can. You're going to need it. Because the key in this is once you deliver the baby, you'll have at least a minimum now of 2 patients. And your hands will be full, and you do not want to be in the back of the truck by yourself when that happens. We're also going to talk about vaginal bleeding. If you remember from last week, we kept saying that the 3rd trimester of pregnancy with vaginal bleeding was very, very important, and it needed to be dealt with right away. We're going to discuss why and what kind of bleeding they'll have. And we're going to talk about anatomy and physiology of a normal pregnancy. Talk about complications of pregnancy, and we're going to deal with assessing the pregnant patient. There's some tips and tricks for assessing, not really just tips and tricks, but things that you want to know specifically for a pregnant patient. We're going to talk about the 3rd trimester bleeding, placenta previa, abruptio placenta. We're going to talk about that. We're going to talk about abortion/miscarriage. We're going to talk about the differences between spontaneous, and there's a few other things, intentional, impending, things like that nature. Ectopic pregnancy, we did cover that last week, but we're going to touch on it again. And one of the things that we did talk about last week was postpartum eclampsia, which is kind of like putting the horse in front of the carriage, the carriage in front of the horse. But now we're going to back up and punt, and then we're going to put it all together with preeclampsia and eclampsia. We will touch on trauma. Again, I know we haven't done shock trauma first. Like I said, this is the first time I have not done shock trauma first. So dealing with a traumatic patient, especially that's pregnant and carrying, you may not understand it fully, but I'll give you the tips and tricks that you need to know what you're talking about. Again, special considerations. All right. So like I said, when we first started this, birth's going to happen regardless. It's been going on for centuries without hospital care. And of course, obviously, the mortality rate and death rate was higher for mom and baby due to complications. If it's a normal birth, all you got to do is shut down camp wherever you're at. If you're in the home and mom's ready to deliver, shut it down and get ready, and then get ready to have 2 patients. That's the good news. The bad news is when things start going wrong. And there's a lot of things that can go wrong, but most of the time, and I would say most of the time, it doesn't happen. You don't have anything that does go wrong. This is just to prepare you for the things that can go wrong and what to expect. There is a possibility that labor can go very quickly. It's called an explosive delivery. And most of these deliveries that you're going to see are going to be in moms that have more than 1 or 2 children. Usually 3rd or 4th child, delivery starts going very quickly. The body is apparently adapted and ready to deliver. Mom kind of knows what's going on. Like we're saying, it's not her first rodeo, so she's been through this. She knows. So her body is prepped and ready, and she's used to being a mom, obviously. So you can have progressive, quick labor. With that being said, if you do have a patient that has had several babies and she starts having the urge to push, you know that it's just time to shut it down. Usually, if it's their first child, you got usually 24 to 36 hours, sometimes a long time. But if it's a third and fourth, you probably, and she does feel the urge to push, you don't have much time. So you probably have to shut it down, set up camp. That's usually what I call it. Shut it down, set up camp, get ready to deliver. And hopefully everything will go smoothly. We talked about the anatomy with the from the ovaries, fallopian tubes, the uterus, the cervix, and the vaginal cavity. Again, not really concerned with the external genitalia of the female. We're really concerned with the internal workings of the female reproductive system. The only difference between this week and last week is now, if you look, you've got a baby in utero. You've got a baby in the uterus. Some key points that I want to point out, we are going to discuss. We're going to talk about the sac that the fetus is in. It's in the amniotic sac. You've got amniotic fluid. You've got an umbilical cord. You do have a placenta. And one thing I want you to remember, they really don't stress on, right yet anyways, is the top part of the uterus, as it stretches up and out, is called the fundus. That will be important post-delivery, postpartum. So, that's what I want you to point out and just know as far as A&P. Gestation. This is where mom is actually technically pregnant. And typically, like I said last week, fertilization of the sperm to the egg or the ovum or oocyte is usually done in the fallopian tube, believe it or not. It's not, it just magically happens inside the uterus. It actually happens in the fallopian tube, hence why you sometimes have ectopic pregnancy. Sometimes it just doesn't make it down. The developing embryo doesn't make it all the way down into the uterus and doesn't implant in the uterus wall and forming the embryo forming there. So again, it wants to recap here. You have a mature oocyte. It kind of pops and explodes out into or releases into the fallopian tube. Sperm meets up with it, and it starts doing its cellular division. It starts forming, and then as it finally comes out, it'll implant somewhere. Wherever it comes out, it'll implant. Talk about the umbilical cord. We're going to go more detail with that. Amniotic fluid in the amniotic sac. We'll talk about if that indeed ruptures, what to expect, and the gestation period and how long that is. Here's some more A&P. One of the things that I do want you to pay attention to, that usually most of these pictures are going to show the placenta attached somewhere up in the actual in the fundus up here. It may not always be the case, but typically, hopefully, it does implant up there. That is ideal. I'll show you why that, if it is not, why it's not ideal, and what can happen from that. But really, truthfully, be told, like, you want the placenta up and out of the way. So the placenta, it's very vascular, meaning that it's got a lot of blood vessels going to and from. Because obviously, for obvious reasons, it's now supporting another life. All the nutrients, the oxygen, the waste that the fetus, as it's developing, generates, it all comes and goes through the placenta itself. So, with that being said, a lot of blood supply goes to this. And we'll talk about mom's blood supply and if she starts having vaginal bleeding in the third trimester and what it means. But it is very vascular, and it is the lifeline and the link, including the umbilical cord, to the actual fetus and fetal development. The umbilical cord. This is kind of tricky, and you need to pay attention to this. It has two arteries which carry blood away from the placenta, and one vein. But these two are swapped in oxygenated and deoxygenated blood. Believe it or not. They're swapped, because you got to think it's coming from mom. So, as it comes into mom, it's got the oxygenated and deoxygenated blood. So, in reference to the baby, away is the artery from the baby, but it's got it's swapped. Sorry, I'm getting kind of tongue-tied. My bad. But just keep that in mind. And here's a picture and a reference for that. So, and another thing about this too is this also acts as somewhat of as a filter, and it'll filter out through. But a lot of like I said, a lot of the oxygen, a lot of nutrients come through the placenta to the actual fetus itself. So that's why the placenta is very important. It needs, and this is key too, it needs to stay attached to the uterine wall. If it starts coming and tearing and shearing away from the uterine wall, that's when you're going to start having issues and problems. The amniotic fluid, the sac is the actual lining that holds the fluid in. The fluid itself is like a buffer or like a cushion. It allows the developing fetus to kind of float in there, and obviously as the fetus gets larger, it will take up more space, and it won't be actually technically floating anymore in the sac. But for the first couple trimesters, it is actually just causing it to float and be a buffer. And it just allows the fetus to develop, and as it's developing, it's cushioned, and it also, if it provides nutrients somehow, some way. Don't ask me how, I don't know. But also what will happen is the oxygen is coming from the placenta itself to the baby or to the developing fetus. But as the lungs develop, the baby will actually start practicing breathing, and it'll actually practice breathing in and out the amniotic fluid. It's not getting any oxygen from it, but it does actually do that. The bad part about that is, as we'll learn as when we have labor and delivery, and we're able to look at the color of the amniotic fluid. Hopefully we can look at the color, because that's very important, because sometimes color is key. But it'll tell you whether or not the baby had its first bowel movement inside that, which is called meconium. So we can talk about that, because if it does start breathing that stuff in and does have a bowel movement inside, that means it literally just took all that fecal material and it just put it inside its lungs. So the color of when there's called the amniotic sacs called membranes. When the membranes rupture, the color of the amniotic fluid is very important. So you got to look at the color, because you need to know if it has meconium or meconium staining. So gestation, 40 weeks, typically 9 months. The trimesters are divided into 3 months apiece. So it's kind of hard to divide 40 by 3, but roughly 12 to 14 weeks each. Different stages of fetal growth happen. We're not really going to go over all that. You just need to know that gestation is 40 weeks. They threw in that you could hear the fetal heart tones about 17 to 20 weeks, and you can actually probably determine the sex of the baby at 18. So let's talk about mom. We're going to really focus on mom as far as through development of pregnancy. What happens is believe it or not, once mom becomes pregnant, hormones are released that actually will vasodilate her. So vasodilating her is going to have her have a lower blood pressure, but she makes up for that. She starts increasing her actual blood volume, overall total blood volume, by 50%. There's 2 reasons for this. One is she's got a developing fetus, and as she increases it from her normal 100% over time to the 150% by the end of the 40-week gestation, she's preparing, or she's developing, and the fetus itself. She's having to provide oxygen, nutrients, and the only way to carry that through is through the blood vascular and through the blood. So she's using like the blood and the hemoglobin to carry more oxygen to the actual placenta to give to the baby. The second fold for this is that when she does deliver, it's a bloody mess. If she has any type of bleeding, she's preparing her body to lose a significant amount of blood. So in a way, it's twofold. She winds up having more cardiac output. It's like, she's having to push and have her heart rate go up. So she's having to circulate more because she's got to carry around more to get more oxygen to the actual baby itself and maintain her natural metabolic state. So she needs more iron. That's going to help make the hemoglobin and make more red blood cells. She is going to take the respiratory minute volume. Like, she'll actually take in more volume. Right now, I believe it's about 5 liters of air, which we consume. She'll actually have to be consuming more because she's using more oxygen to feed the fetus and develop the developing fetus. Her gastrointestinal function does decrease. And with this, this increase in actual overall blood volume, and the lowered blood pressure, it's difficult to actually get the return circulation sometimes, and that's why she'll start having fluid shift, and she'll start having pedal edema. She'll start having swelling in her feet. And if you've ever known a pregnant woman, you've known these things. Like Like when she goes to see the doctor, they check her iron. She's always kind of a little bit more short of breath, and obviously so. I mean, you carry around an extra, 25, 30 pounds, and let me tell you, you're going to be sucking wind too. And they'll usually complain about their feet and how they're swollen and they hurt. All right, so we're going to talk about some vaginal bleeding and the complications that come from. So the first thing when we have vaginal bleeding, the first trimester or within the first 20 weeks, we typically are going to associate it with the fact that there's an abortion. Now, there's a stigmata when I say the word abortion. When I say the word abortion, most of us think of a young lady who is pregnant, maybe out of wedlock or for whatever reason, and she's electing to go to a clinic and have an abortion. But believe it or not, abortion, it has more to it than just that. There's different types of abortion. There's a spontaneous abortion. And typically, if there's something genetically wrong with the developing fetus, it will spontaneously abort itself because it just can't develop correctly. For whatever reason, there's a genetic complication, and it will spontaneously abort. It basically aborts itself. It's nothing mom did. She didn't go to the clinic. Nothing bad happened. There's not a bunch of picketing, rioting people outside that are pro-life, and she's going to have an abortion, and it's just all those bad things. Those things are called elective abortions. And regardless of our feelings, and I'm not going to interject, and I don't want anyone else to, but they're out there and they do happen. There is such a thing called a threatening abortion, and there's going to be some visual pictures to go along with this, so just kind of bear with me as we discuss it, and then I'll visually show you. A threatening abortion is where there's a possibility that there is a complication and that the developing fetus is in jeopardy. And it's usually associated with vaginal bleeding of some sort, and that's usually the indication. Now, there's a word called miscarriage. It's kind of the same thing. It usually has to do with the fact that the fetus is not technically a fetus. To start with, for the first 8 to 9 weeks, it's called an embryo. And then after that, they kind of kick over the terms and call it a fetus after that. So typically where they're going to have these miscarriages or spontaneous abortions are typically within the first 8 to 12 weeks. Like I said, they kind of throw out that 9-week mark is where it's called an embryo versus a fetus. So it's all kind of a gray area. 40 weeks, 3 trimesters, 3 months apiece. So it's all kind of gray, but at the end results the same. So usually the threatening abortion is something's happening. It's not mom going to the clinic and trying to get an abortion, but something's happening to the fetus. And typically what needs to happen is to avoid the miscarriage / spontaneous abortion. Kind of the same things when we're talking about this. Same terminology, meaning the same, different terminology meaning the same thing, is that they usually going to put mom on bed rest till the vaginal bleeding stops, until the fetal development comes along where it's a lot more stable. There's something called an imminent abortion, and typically what it means, an impending impending means there's something wrong, but they might be able to stop it. And usually what's kind of the defining factor is the fact that the amniotic sac is still intact. If it's still intact and the placenta is still attached, then there's an impending, but they can probably try to give mom bed rest, and they can try to stop it. An imminent abortion typically means that the amniotic sac that the fetus or the embryo is in has ruptured. And that's kind of the key between that. So an imminent abortion means that it's happening. It's just a matter of when she's actually going to have the overall miscarriage, and the artifacts of conception, what's left of the embryo that's now more than likely deceased, come and pass through her vaginal cavity. I'm trying to be sensitive in a way where it doesn't sound horrible, but it's a horrible thing. And really, truly, the problem with this is the emotional part. Because most women, when they do find out they're pregnant, they go through a series of emotions. I don't know if any of you, including men, have gone through a pregnancy scare with a significant other that is female, and there's a whole range of emotions, and so there's a whole emotional piece to this that we're not even really including, but we do need to take the time to mention. So more than likely, when this is happening, usually it is very emotional for the person having the abortion, and or the miscarriage, for lack of a better term, miscarriage, and what's happening inside of her mind as well as what's happening to her body. Treatment is pretty much. I know you guys can't do this yet, but you're going to provide supplemental oxygen. You will talk about doing IV and doing a fluid bolus depending on blood pressure. But again, remember, she is bleeding. She is more than likely bleeding, not to death, but she is bleeding, and you need to treat it with like it's shock trauma. Again, I realize we haven't gone over shock trauma, so just keep that in the back of your mind. There is such thing as called incomplete abortion, where there are still pieces, they call it products of conception, are not fully expelled, but there's still pieces in there. With that, as long as there's, even after delivery of an actual full-term baby, if all the products of conception, including the placenta, are not expelled correctly, and even a little bit of piece that's left in there, there will be continuous hemorrhaging. The only way to do that is to completely have all the products of conception removed. So, as long as that's not done, the vaginal bleeding will continue. They will progressively keep losing blood. They will go into shock, and then you're left dealing with trying to manage this patient. Here's a visual for you. If you'll notice, under threatening, the amniotic sac is still intact. There's probably just some vaginal bleeding. There might be an issue with the actual placenta embedding into the uterus. Inevitable. If you'll notice, it's kind of harder to see, but if you do pull up the PowerPoint, the amniotic sac, also known as the membranes, have ruptured. And once the membranes have ruptured, depending on how bad and how far along mom is, you can keep that up. If it's just a small tear and she's just leaking a little bit, the body keeps making amniotic fluid. So if she's making enough to keep it up, but the only problem is, and I think we'll talk about this here later, is infection. So we'll talk about why that is. Incomplete is the products of conception, most of them, including the actual embryo itself or fetus, depends on how far along she is, has been expelled out through the uterus, the cervix, and out through the vaginal cavity. But there's still some pieces left. I know it's kind of hard to see, but there's still some pieces left, and it's going to be causing vaginal bleeding. We talked about ectopic pregnancy. I've kind of touched on it before, where the oocyte is fertilized by the sperm, and somehow it can't pass through due to scar tissue or it's too narrow, the fallopian tube into the uterus, and it winds up embedding in the fallopian tube wall. And then it continues to grow, and then more than likely the danger is not only the fact that it's growing there, but eventually it will rupture. So that is life-threatening, and we've already kind of touched on that, and I'm not going to beat a dead horse with that. Third trimester bleeding, here it is. We said it over and over and over again, and now it's time to figure out why and how and what we're looking for. There's two things, really, that come with especially third trimester vaginal bleeding. Again, third trimester vaginal bleeding. The first one's called abruptio placenta. What this is referring to is the fact that the placenta is implanted and it's growing as the fetus grows. But it can be for any reason. Trauma, they talk about drug use, alcohol, diabetes, whatever, hypertension. Somehow, some way, the placenta starts coming off and shearing from the actual wall. Now, there could be enough of the placenta holding it in, or the amniotic sac is so tight in there and it's holding the blood back. You may not have vaginal bleeding. You may have a trickle of vaginal bleeding, or it can go from none, trickle, all the way to a lot of bleeding. Because remember, the contents of conception are still technically in there. So if it's in there and you have contents of conception, including the placenta, it's going to still bleed. There's nothing you can do except get her to surgery so they can remove the products of conception out. The bad part about this is depending on how far along she is, the fetus may or may not be viable. There is a window in there where there's lung development. And what's really happening is the surfactant in our lungs that hold our alveoli and cause them to pop are developing at that time. If the fetus is born before that happens, it's rough. It's rough. They have said, and from what I've talked to, is the people that do this kind of care in some of the larger hospitals, 27 weeks is where you're starting to push it. They have said, and I can only quote them, I don't know, but they've had, they call them weekers, based on the weeks of gestation. They said they've had 22 weekers come out and make it. Now, they will probably have a myriad and a host of medical problems, especially with respiratory problems, but they still live. And they're hooked to vents, and mom can't hold them, and they're teeny little preemies, and it's bad juju. So, if this happens, you have abruptio placenta. If it happens, this is bad juju. Again, you're not going to probably see or may not see bleeding. It's a possibility that you may not see bleeding or light bleeding. Again, because of what the blood being held back by the placenta or wherever the placenta is implanted and the actual amniotic sac. Also, with this, there will be pain, a shearing, tearing sensation. There should be pain with this. So abruptio placenta, possibility of no to minimal bleeding, and pain. Those are the things that you need to remember. In contrast to placenta previa. And what placenta previa means is that, you know how I said that it's probably a good thing that, or it's a good place for the developing embryo to implant and start having its placenta grow in the fundus. Well, this winds up happening to be somewhere in and around the cervix. 180. We've done a 180 where the implantation should be. It should be up and out and away from the cervix, but it's not. It winds up being that it is first and foremost. And what happens is with a woman that's pregnant, typically she does dilate. Her cervix will dilate, and it's to 10 centimeters, and it's pretty much pulled back out and away, and the vaginal cavity and the uterus are pretty much now, there's no cervix holding it back. So, as the woman prepares for labor, that's only natural that at some point before her delivery, before her 40 weeks are up, the cervix is going to start to pull away and get ready. Believe it or not, the more children she's had, the sooner or the more abrupt that will happen. The body, like I said, it's really, really kind of a miracle of science that the more children a woman has, it seems like her body kind of has that knowledge and that stored knowledge and what to do and how to get it done, son. So, with that being said, though, if the placenta is first, placenta previa, you can have bleeding. Now, with this, there's no tearing, shearing pain. There's all of a sudden, there's some light bleeding, depends on how quickly she's starting to feel. She might have Braxton Hicks contractions. We'll talk about that here in a minute. But her body's getting ready, so as the cervix starts to pull open and away and get out of the way of the uterus to go ahead and have it in line with the vaginal cavity, you start having the bleeding. It's painless. It is painless. It is supposed to also be a bright red blood coloring. But as we talked about last week, you may not be able to tell so much the color of the blood. It'll just look like they're bleeding. So, this will be painless. And that's due to the fact that the placenta is over the cervix. There you go. There's some representations. You've got the normal placenta implanted up near the fundus. Placenta abruption or abruptio. The placenta is pulling away from the uterine wall due to the fact that it's so vascular. There's going to be a lot of bleeding. And placenta previa is where it wound up implanting down in and around the cervix, and it's grown over top the entry of the cervix. Now remember, also, with the cervix, it's going to open to the vaginal cavity and pretty much make the uterus and the vaginal cavity kind of one. It's going to pull up out of the way. That's the baby's way out. If the placenta is still there, that's bad juju. So with all of these are true emergency. This is why they said third trimester bleeding is a big deal. I threw this slide in here for you to kind of remind you, so you can have like an actual written down assessment. Placenta previa versus the abruption. Again, abruption will be painful, tearing. They say dark colored blood. Where placenta previa will be supposedly a bright red blood, and it's painless. All right, so we're talking about mom and how she is going to naturally be hypotensive. Her new normal is going to be what we would consider hypotensive. Again, she has hormones making her vasodilate to get ready to start having an increase of her overall blood volume. Again, that was twofold. Remember, she has extra blood for the fetus to help actually be able to oxygenate and transport nutrients to the fetus. And she's getting ready to bleed and get ready to have damage done. And so that way, when she is postpartum, when the baby's gone, if she loses a third now of her blood, if she loses a third of her blood, which would normally send people into shock, if she is postpartum and loses about a third of her blood volume, that's roughly 50 percentage points, which will drop her down to 100% of what she was to start with, which is where she needs to be. That's the whole point of that. It's kind of neat how that works out. But, so when she starts getting around the quote-unquote normal, adult normal, 130 over 80, 120 over 80, she is actually considered hypertensive. They use the diastolic marking of 110. That's actually true for normal adult patients as well. But that starts putting her at risk for hypertension. This typically is going to start developing after the 20th week. So we talked about the bleeding issues before, and now we're talking about hypertensive stuff. So we're still in the cardiovascular system, but this stuff is going to start being seen 20 weeks before. Something called preeclampsia. And really the triggers are for preeclampsia, or what makes her preeclamptic, is she's going to have hypertension for her being pregnant, hypertension for her, and she's going to start having protein in her urine. What's happening is that she's hypertensive for her body, and now the blood pressure is kind of slamming against her organs, and her organs don't like that. They don't like being slammed up against, and so she starts having protein molecules in her urine. There's some other factors too. Let's go and get to them. Again, she's hypertensive. She might have a headache. Usually it's a very bad migraine, which makes it, they say visual disturbance, but I think she's just very sensitive to light. Like, light will bother her. She'll want the dark. She'll want to have her eyes closed. She is agitated, and because of the headache and the feeling like crap, she does have nausea and vomiting. But the telltale signs for this, she's going to be hypertensive for her, not the normal. She might be close to normal or a little bit above normal, but that's hypertensive for mom, especially after 20 weeks. She'll have kind of the photosensitivity, she'll be really sensitive to light. The protein urine, that's going to be the big key, and she'll have cankles. Really bad cankles. With the hypertension, she's going to have fluid start shifting, and usually it'll start down in the feet, so she'll have really bad pedal edema. So those are your signs and symptoms to indicate that she is preeclamptic. What makes it the difference between eclamptic and preeclampsia and eclampsia? Seizure. Once she has a seizure, she is now considered eclamptic, or she is suffering from eclampsia. That's the difference. And unfortunately, it's hypertension driven, and not too much you can do about it except for try to treat the signs and symptoms. You'll need ALS Intercept to try to stop the seizure itself and get the patient to stop seizing, and give benzos to treat that, which will be an ALS Intercept for you guys, and basically try to just manage the patient as best you can. On the flip side, they call these all hypertensive disorders. There's not all hypertensive disorders. As a woman's gestation continues, the fetus develops. It gets bigger. It starts pushing on things. Starts pushing on the bladder, because the bladder is up underneath the uterus. So as it grows, it's pushing on the bladder. It's pushing on the intestinal tract. And believe it or not, women who are pregnant sometimes have gas from it, and they'll accidentally let a little flatulence fly, and they're very embarrassed. But it's natural. It's normal. The fetus, as it grows up, more up and than out. So it starts coming into the diaphragm, into the lungs, which makes breathing difficult. We already talked about the minute volume has to go up to keep up with the demands. So now they're getting less area to expand the lungs into, because the baby's starting to grow. With that also being said, there's the weight of the baby makes them uneven and imbalanced. So if a woman was to lay down supine, believe it or not, the inferior vena cava is not as strong as the artery. Remember, there's no real strong arterial walls. It's just got valves in it. So what happens is she starts wiping out her preload. She starts wiping out and minimizing, basically holding down pressure and making it so that the venous return in her inferior vena cava to the right atria is minimized. So she's getting less blood return because of it. So that's why most women who are pregnant, especially after the 20th week, cannot lay supine. They've got to turn on their side. The best place or the best way to turn is on their left side. Some reason it pulls the weight of the fetus off and away from the inferior vena cava and allows adequate blood return. So this is not a hypertensive, this is actually a hypotensive disorder. Alright, so hold on to your seats because this is going to get kind of wild. I'm just going to show you. Remember we talked about blood typing. We talked about A, B, AB, and O. And the fact that you can have antigens or no antigens. And antibodies or no antibodies. A has the A antigen on the red blood cells, and it has the B antibodies. The reverse is for type B. B has the B antigens and the A antibodies. If you have A and B, you have 0 antibodies. If you have no antigens, you have both. Well, to make this even more confusing, even if you did master this and understood this, we're adding in something else called the RH factor. And this is either you have it or you don't. It's called antigen D, but they really just call it the RH factor. So now you either have it, positive, or you don't have it, negative. So when we're blood typing, there's no longer 4 blood types, there's now 8. You either have the antigen D marker, which makes you RH positive, or you don't, which makes you RH negative. The problem with this is if you have an RH positive fetus and you are an RH negative mom, that means that you have the antibodies as mom feeding the placenta that has antigen D. Now, baby's making his or her own blood cells, and genetically it wound up having the markers for the RH, or also known as antigen D. So it's RH positive. Baby's positive, mom is negative. Mom has the antibodies. Baby does not. Baby has the markers. Well, as mom is supplying blood, it'll start doing hemolysis, which means it's going to come across the placenta, feeding nutrients and oxygen to the baby, and as soon as it runs into one of the baby's blood cells, it has the antibodies in the blood, it will attack it and destroy it. So that has to be identified fairly quickly. Every time mom has a baby, it actually gets worse. It's kind of like getting sensitized, and then you build up more, and then if mom continues to genetically have RH positive babies and she's RH negative, she'll actually attack the fetus's blood cells a lot faster each and every time she gets pregnant. So this is a big deal. So when mom gets prenatal care, she's usually blood type. If she's positive, no antibodies exist, fantastic. If she's negative, then they start worrying. They can give medication that will somehow mask baby's blood, or it just makes the antibodies not attack. It's amazing. I don't know how they do it, but they did it. They figured it out. Much smarter than me. That's why they get paid the big bucks. But just keep that in mind. That is a possibility. It's called isoimmunization, RH sensitization, yada, yada, yada. I pretty much explained it to you. Hopefully it made sense. All right. There is such thing as called gestational diabetes. What that means is mom's never been a diabetic in her entire life. Never had issues with her blood sugar. There's probably no family history, nothing. All of a sudden, she gets pregnant, and now she starts having issues regulating her sugar. Another thing they do in prenatal care at some point is they start testing for this. They'll test, I think, between the first and second trimester and the second and third trimester. What she has to do is she has to take this sugary drink. She has to drink it, I think, several hours before She has to fast all night, drink that, and then she goes in, and it's nasty. And then they check her blood sugar and see if she has enough insulin to deal with that. So she can have gestational diabetes. As soon as she has the baby, done. She never has diabetes ever again in her life. But for some reason, when she's pregnant, or while she's pregnant, she has diabetic issues. It's the same thing. You got your 3 Ps: polyuria, polydipsia, and polyphagia. And she has issues with it, and she struggles with it, and she has to take insulin sometimes. Sometimes it's oral medication like metformin. But for all intents and purposes, she's diabetic during her pregnancy. Again, oral medication, sometimes insulin, diet control. She can go either way depending on what happens. She's more likely hyperglycemic, and then she takes her medication or insulin shots. She becomes hypoglycemic. The bad juju is, I'm going to just skip because I got a picture. The bad juju is, if she's always high blood sugar and she doesn't catch it, she's going to make a big baby. Meaning that she'll have a huge infant and may not be able to pass it through the vaginal cavity because it's that big. We're talking like 10, 11, 12, 13-pound babies. And we're not talking about small little children. We're talking about healthy, chunky babies. They get bathed in glucose, bathed in sugar, and they wind up storing it as fat, and it makes them big, fat, healthy babies. Now, I don't know, and I am curious, I probably should have found out before I recorded this, if the child winds up having diabetic issues. I'm not sure if they do or don't, but I don't think they do, because otherwise I think I would know. But it does make for big, fat, healthy babies. So, if you always check a D-stick on mom. It always helps. And part of your sample, you'll find out the last time she ate, and if it sounds reasonable in the past couple hours that she's got a high blood glucose. But if she's got like 350, 400, there's something wrong. There's something called hyperemesis gravidarum. We're going to actually talk about what grava and para means here in a minute. But basically what it means is that they just consistently have morning sickness. They are sick and nauseated all the time. And they can't help it. They're just constantly throwing up. Zofran used to be the medicine of choice to fix this. And then they started linking it to possibly having fetal development issues. So they are no longer recommending it. They put a pregnancy class on it. I forget. It's kind of that it might be harmful. But it used to be every woman's friend, man. Every woman that I had known that had morning sickness would be eating Zofran like candy, and it would help them. It would feel so much better. And then they started linking it to that issues, and so now there's some questions about it, and I really haven't heard anything since they linked it to those issues. Premature rupture of membranes. Basically, this is when the amniotic sac, for some reason, whether it be trauma, maybe it was weakened state, sometimes the doctor will go in and rupture the membranes when it's time to have delivery and mom's not presenting any signs, because it can happen. Mom can go 40, 41 weeks, 42 weeks, and basically the doc will go in there and he'll take a little sharp little object. He'll go in there and he'll nick the membranes and he'll pop it open. So, like I said, that you can have small leaks, and mom's put on bed rest, and they try to make the amniotic fluid last if mom's able to make it as fast as she's leaking it. But if she has the rupture is her water breaks. If you ever heard like, oh, my water just broke, that's what happens. She's got a rupture in membranes. The premature part is where it gets dangerous, because at some point, if it's left, I believe, for roughly about 6 hours, or for a while, for several hours, she's now at risk for infection. Remember, there's a lot of bacteria in the vaginal cavity that helps actually maintain balance in the vaginal cavity. Well, that bacteria is not probably good for baby to be exposed to for too long, and she might have an STI, anything. Once that sac is ruptured, baby is exposed to the environment, baby can be at risk for infection. So, with a premature rupture of membranes, that's bad juju. Also, if it's not before her time. If she's usually around 38 weeks, they're okay to deliver baby. They feel she's ready. They still kind of say it's premature, but they're okay with that. But if she has a rupture of membranes before that, they're talking that the baby might be preemie. So they get worried about things like that. So the longer baby can stay in gestation, the better off it can develop. So if she does have a premature rupture of membrane, more than likely delivery is imminent. So it's coming. We talk about trauma. Remember, we were talking about the blood volume. One thing I do want to kind of just point on, trauma, I know we haven't really talked about it, but I do want to talk about it now, is that with trauma, your extremities start shunting blood. It's called, they vasoconstrict blood to your core, which is all your internal organs, your abdomen, your thorax, and your head. So they start shunting. One of the places that they'll start shunting from, if there's significant trauma and mom is losing a lot of blood, she's hemorrhaging somewhere and the bleeding's not controlled or stopped, especially if it's internal, you can't do anything about it. Excuse me, Rona. What's going to happen is they're going to start, the mom's body is going to start shunting blood away from the fetus. That's bad. So if there's significant trauma, that means the fetus is no longer going to get what it needs, and now it's considered a parasite. It doesn't need to have all this. Apparently, the body views pregnancy as a luxury, and I know that that's a horrible thing to say, but it's considering it kind of like a luxury. Like, we need to save mom. It doesn't matter about this. If you look at it kind of like over time, maybe the first time a woman menstruates is going to be when she's 15, maybe. Sometimes younger, depends. And then she probably stops at about age 55. So she's got 30 good years. She can probably have approximately up to 30 children or more. So losing one in the grand scheme of things to save mom to have more children is not nature's way. I'm not saying that I believe in that, but I'm just saying that that's how it's somewhat viewed. And you'll meet doctors that feel the same way. They believe in saving mom. And most moms are like, save baby. So there might be some issues, and you may run into that. I just wanted you to be prepared for the fact that that does exist. Regardless of what your beliefs, that's what the practice is and the thought process. So, when you have trauma to a pregnant woman, if you can identify where the bleedings come from and stop it, that will help mom and baby. One of the things that you will deal with, and I've seen very, very, very commonly, is mom's pregnant. She's probably about 6 or 8 months, and she gets in a fender bender. She's rear-ended, and her stomach hits the steering wheel. She then becomes very, 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 very concerned about baby. She's like, oh, I've been sitting here for 5 minutes. The baby was moving, and I felt it moving, but now I don't. So they're really concerned. More than likely, usually baby's okay. Again, depending on how far along mom is. Remember, that cushion of the amniotic fluid in the amniotic sac is there. It's there for that, one of those reasons right there. But, still take mom. Transport mom. Transport her. If she wants to go to the hospital, transport her. Take her. Let her get reassured that they can hear fetal heart tones. Some ambulances will carry like a little Doppler that you can actually hear fetal heart tones, and it'll make mom feel a lot better if she can hear them, and then she won't want to go to the hospital as long as she can hear her baby's heartbeat. So, like I said, I've ran into that a lot. Kind of talked about all this, take her to the hospital. And again, your main concerns is you can't do anything for baby, especially if baby's not timed to come out yet. You can't do anything for baby, but what you can do is you can manage mom. Manage mom will help baby. Airway, breathing, circulations, those are still your highest priority, especially in your trauma assessment. If you have to backboard mom, and there's a picture in here somewhere, it's probably coming up next. If you have to backboard mom, I know we haven't gone over that either, but in the event that you have to backboard mom and put her on a long spine board, we talked about that supine hypotension, about how the blood can't get back to the right side of the heart because the baby is weighing on the inferior vena cava. With that being said, take and tip the backboard. Let's see. I'm going to try to skip ahead. No, it's not there. It's there somewhere, but basically tilt the backboard. If she's laying on it like this supine, tilt it over to the left. Same thing. Remember, mom's supposed to be in the left lateral recumbent position or laying on her left side. You can tilt it and you can make things so much better. Again, when we get into trauma, it's the same. Treat mom the same as you would any other, and you may have to be more aggressive than usual. Not saying you wouldn't be aggressive to start with, but she's carrying a baby that also needs oxygen and blood flow and nutrients. So keeping mom fully, oxygenated. Make sure her pressure's up with fluids and stuff like that. It's very essential to keep mom and baby. Healthy mom has healthy baby, hopefully. They do talk about cultural considerations. I really can't tell you where I would see cultural considerations because, and what I've seen in different cultures is that children are very treasured regardless. I know that some cultures don't value female offspring as much as they do male, as much as I hate to say that. It is a possibility. Also, really, we get back into if there's a complication, are we looking to save baby or are we looking to save mom? There's that dilemma. Again, just be prepared to try to help out. When this happens, I'm just going to tell you, follow your protocols. Your protocols will overrule anyone else. And if you can't handle the situation with your protocols and you're meeting too much resistance, online medical control. Put it on a doctor. Teenage pregnancy. Now we're getting some medical legal issues. Is mom technically an adult if she's pregnant? Yes. She is now responsible for another life. If she's under the age of 17, she is now an adult. The true problem lies in if she's 15, has the baby at age 15, as soon as she has the baby, is she still an adult? My answer is yes, because she is now caring for that young life. If she is indeed keeping the baby and going to raise it, but some parents don't see that. Some say that that's still my daughter. She's underage, and I'm taking care of my child and her child. So there's some medical, legal, ethical issues there. Hopefully you won't have to deal with that. Talk about patient assessments. Let's go ahead and jump to some key terms. These are some key terms. I don't know. They're bolded, kind of highlighted. You probably should know these and what they mean. But when you're doing one of the assessments, you have something called gravida and para. These two right here. These are important. You may even see in some assessment software like a G and a P if you click that the mom is pregnant. What you want to find out is, one of the things you want to know is gravida, how many times she's been pregnant, regardless of whether she's miscarried, had twins, whatever. Gravida is how many times, noted times she's been pregnant. Para is the number of live children she came to bore. Even if the child dies after being born, it's still considered a successful delivery because it was a So typically, if it's the first one, you'll have gravida 1, para 0, but they'll actually call it a prima gravida. I can't really say all these, but I'm sorry if I botched them. But she's pregnant for the first time. But you can have gravida 2, para 1, meaning this is her second time she's been pregnant. And she obviously hasn't had the baby yet, but she's had one successful birth. So she's 1 for 1 and now working on her second one. Another one is prima para, a woman who has only had one delivery. So prima gravida, she's pregnant and hasn't had it yet. Prima para is she's only been pregnant once and had one kid. Multigravida has been pregnant 2 or more times. Nulliparas is a woman who's never delivered a viable newborn, even though she's been pregnant before. You may meet those people. They're in here. Worry about them. My main concern are these first 3. Again, though, they're here. Hint, hint, nudge, nudge, wink, wink. Some more in here. Multipara, woman has delivered 2 or more viable newborns. Grand multipara has delivered 5 or more. Okay. It's kind of too much, but again, they're bolded and they're there. Hint, hint, nudge, nudge, wink, wink. So you start getting your patient assessment, size up, all that stuff. Yeah, it's all kind of the same. Your ABCs of life. Really where you want to get into, especially if it's your history. Oh, there it is. There's the picture. Why the hell it's there, I don't know, but there it is. One thing I want you to really pay attention to is, and where's it at? We're going to get there. So you want to ask about gravida para. How many times have you been pregnant? How many times have you had a good outcome, good delivery? You want to know how long mom has been pregnant now, This time, how many weeks pregnant are you? And pray to God it's 40 if she's having a baby. If she's ever had complications before in any of her previous pregnancies. That's something you may want to know because it might be something that's going to be doomed to repeat itself. One thing you need to know is if she's crowning, feels the need to push, or feels that she has to have a bowel movement, which is also an indication that she needs to push. She's not really having a bowel movement. It's just the nerves that stimulate bowel movement are having pressure put on them, stimulating them because of the baby's head. If she's crowning, set up shop, make camp right then and there because it's coming. It's going to be over in about 10 minutes, hopefully. If not, then there is issues and you need to go and go fast. And we'll talk about delivery issues in our next segment. So again, how many weeks pregnant are you? When is your due date? That's another good history question. When are you due? Okay. You do want to know if it's first baby. The reason being is if it's not, then more than likely this is going to go a lot faster. And how many babies she has is probably the faster it's going to go. Contractions. Are you experiencing contractions? All right. How far apart are they? Okay, about if they're 2 minutes or less, that's an imminent sign delivery is happening. How long does the contraction last? She might be like, oh, it's only about 5 or 10 seconds. If it's 30 seconds to a minute, again, even if they're 3 or 4 minutes apart, delivery is probably imminent. Again, do you feel the urge to move your bowels? Do you feel like you have to defecate? Spotting and bleeding, you probably want to know really, truly what color and how much. What you're really looking for is the fact that if there is any spotting, there's something called a mucus plug in the cervix. And as the cervix starts to dilate, it loses its plug. And it's like a rusty brown color. So you want to know if the mucus plug's been lost. Also, you want to know if it's active bleeding, if she has a ruptured of membranes, if she's basically her sac has been ruptured or she's her water's broke, and what color it is, because again, as we'll talk about when we're delivering the child, that's very important. Don't let her go up to go to the bathroom. The reason being is if she feels she has the urge to push and take a number 2, more likely she'll wind up with a child in the toilet. Again, if she has to move her bowels, it's more likely because of the nerve plexus being pushed on and she is going to have imminent delivery. If you can, go ahead and do a secondary assessment. If you can, if you have time. If you can get the fetal heart tones and you do have a Doppler, fantastic. If not, if you can listen with a stethoscope, listen to them, see if you can find them, make sure that they're good. The thing that you want to do, if she is having contractions, you do want to listen to the fetal heart tones. While she's having a contraction, try to get timed with her. If you do have time and it's not an imminent delivery, you want to listen to the heart tones. If, by some chance, you catch the heart rate, which is usually roughly around like 180, and I know it's really fast, but for a newborn fetus, 180 is not bad. 160, 180, that's normal. It's called a decel. And basically means is if mom's having a contraction, she's going to start squeezing down on the newborn. The baby's going to be in trouble, and you'll know that the baby's in trouble and that there's a problem if the heart rate starts to decelerate with the contraction. If the heart rate starts dropping down, 120, 100, 80s, and you can hear it, obviously, you're going to know the difference between 180 and 80. 100 beats per minute, you're going to hear it. So if the baby starts having pressure pushed down on it and heart rate starts decelerating quite a bit, their mom's probably in trouble. There is such things called a Braxton Hicks contraction. They call it false labor or false contractions. It's not really false. Like I said, the body does start prepping, and sometimes it starts prepping early, and they start feeling the contractions, the cervix starting to dilate. It happens. And it happens early, especially the more pregnancies they have. Like I said, the body's a beautiful thing. It kind of has the experience and the knowledge. Like, oh yeah, we're going to do this again. So it's getting ready to do that. Let me tell you right now, if you roll into the ER with possible suspected labor and you haven't A, looked at her vagina, and B, she's still wearing pants, shame on you. Now, I do believe in trying to use a female person that is on scene, whether it be a family member or whatever, whoever they're comfortable with, because I really don't want to look. All I want to know is she crowning? No? Fantastic. Is she bleeding? No? Fantastic. Anything coming out that shouldn't be coming out? Fine. Fantastic. Good. We're where we need to be. Once that happens, you better look. If that's not happening and it's going south, then you need to look and figure out what's going on and what you're going to do. So, she cannot wheel into the ER with her pants on. That's a no-no. She cannot come in and you not having someone visually inspected her vaginal area. No. So, again, protect her privacy. If she'd rather have a family member look instead of you looking, it's very understandable. Just work with what you got and roll with it. All right, reassessment, duh. If she's active labor, probably 5 minutes. Do the best you can with blood pressure and vitals and stuff like that. So we start talking about the emergency spontaneous abortion. There's nothing you can do about it. Again, it's emotional support and it's happening and you can't stop it. So try to help control bleeding. You probably have to use some sort of trauma pad to collect blood. I know it sounds horrible, but it's kind of what has to happen. Again, we went over third trimester bleeding, placenta previa and placenta abrupto or abrupto placenta. If you can figure out when the bleeding start, what were you doing? Was it like during sexual intercourse? Because believe it or not, guys, pregnant women do have sex. Is there abdominal pain? Is there any pain? How long have you been bleeding? Maybe judge what color it was, if you can judge the blood color. Things of that nature. All right, ectopic pregnancy, we did talk about the fact that if it's in the fallopian tube and it grows, that's bad. If it grows and ruptures, that's even worse. We talked about preeclampsia, the hypertension, the protein urine, the edema, the pitting edema, making cankles, some nausea, vomiting, sensitivity to light, headache, those things are what's going to be eclampsia. And then obviously with the eclampsia, we're going to have seizure. Supine hypotensive syndrome, I pretty much told you how to handle that, like put them on their left side. Gestational diabetes, you kind of just treat it like normal diabetes. Sugar's high, start some fluids. If it's low, you might be able to do some oral glucose, or you may have to give some D50 or some D5, something like that, whatever you carry. And then this ends our segment. The next segment we're going to talk about is actually the delivery of the baby and what can go wrong from there.